Neurohumoral activation in heart failure represents a classic physiological paradox. Short-term evolutionary compensatory mechanisms designed to maintain blood pressure and vital organ perfusion during acute volume loss transform into the primary drivers of progressive maladaptive disease. When cardiac output falls, arterial underfilling unloads high-pressure baroreceptors in the carotid sinus and aortic arch and renal mechanoreceptors. This triggers an immediate, relentless cascade across three primary neuroendocrine axes. The interplay between the central nervous system, failing myocardium, and circulating hormones creates a self-reinforcing loop of systemic vasoconstriction, volume retention, and direct tissue toxicity. As the cardioregulatory center perceives diminished effective arterial blood volume, it drives sympathetic outflow and renin release, ultimately increasing cardiac workload and accelerating ventricular remodeling. The three maladaptive axes. 1. The sympathetic nervous system. Loss of inhibitory baroreceptor tone leads to a massive outflow of norepinephrine and epinephrine from sympathetic nerve terminals and the adrenal medulla. Increases heart rate chronotropy and contractility inotropy while causing potent peripheral vasoconstriction, driving up left ventricular afterload. Chronic exposure to high circulating catecholamine levels induces myocyte apoptosis, triggers life-threatening ventricular arrhythmias, and causes a structural downregulation and uncoupling of myocardial beta-1 adrenergic receptors. Renal hypoperfusion combined with direct beta-1 stimulation of the juxtaglomerular apparatus prompts the continuous release of renin. Angiotensin II acts as a potent systemic vasoconstrictor and directly stimulates myocardial and vascular hypertrophy. It also triggers the adrenal glands to release aldosterone and the posterior pituitary to secrete vasopressin. Beyond driving distal tubular sodium and water retention, aldosterone is a potent profibrotic hormone. It stimulates fibroblast proliferation and collagen deposition within the myocardial interstitium, stiffening the ventricle and worsening diastolic compliance. Arginine vasopressin, also known as antidiuretic hormone, is released non-osmotically in response to perceived arterial underfilling. By binding to V1 alpha receptors, it contributes to systemic vasoconstriction and increases afterload. By binding to V2 receptors in the renal collecting ducts, it drives pure free water reabsorption. This dilutes serum sodium, making dilutional hyponatremia a classic clinical hallmark of advanced end-stage neurohumoral activation. To counteract this profound vasoconstrictive and volume-retaining onslaught, the failing myocardium secretes natriuretic peptides ANP and BNP in response to increased wall stress and ventricular stretch. The natriuretic peptide system attempts to promote vasodilation, natriuresis, and diuresis while directly inhibiting renin and aldosterone synthesis. However, in chronic heart failure, this favorable axis is completely overwhelmed by the sheer magnitude of renin-angiotensin-aldosterone system and sympathetic nervous system activation. Its efficacy is further blunted by target receptor desensitization and rapid enzymatic degradation by circulating neprilysin. Translation to guideline-directed medical therapy. Modern pharmacological management of heart failure with reduced ejection fraction is fundamentally an exercise in targeted neurohumoral blockade, shifting the therapeutic focus from simple hemodynamic support to interrupting these toxic cellular pathways. Sympathetic nervous system, primary pathophysiological harm, catecholamine toxicity, apoptosis, arrhythmogenesis. Targeted therapy, beta blockers like carvedilol, metoprolol, succinate, and bisoprolol. RAS, angiotensin II. Primary problem, vasoconstriction, afterload mismatch, myocyte hypertrophy. Targeted therapy, ACE inhibitors and ARBs. RAS, aldosterone. Primary harm, interstitial cardiac fibrosis, potassium wasting, volume retention. Targeted therapy, MRAs, spironolactone, eplerenone. Natriuretic peptide, favorable counter-regulatory system blunted by enzymatic breakdown. Targeted therapy, ARNI, sacubitril component inhibits neprilysin. By deploying an ARNI alongside a beta blocker and an MRA, foundational therapy simultaneously severs the toxic renin-angiotensin-aldosterone system and sympathetic nervous system feedback loops, while artificially preserving and amplifying the heart's endogenous protective mechanisms. Beta-1 adrenergic receptor downregulation and desensitization is common in chronic heart failure. In chronic heart failure with reduced ejection fraction, the continuous flood of synaptic and circulating catecholamines forces sarcolemmal beta-1 adrenergic receptors into a state of relentless occupancy. Rather than allowing this hyperadrenergic state to drive unchecked calcium entry, which would trigger fatal myocyte hypercontraction, energy depletion, and necrosis, the myocyte initiates a self-protective multi-tiered dampening cascade. This process occurs across a strict chronological continuum: uncoupling seconds to minutes, internalization minutes to hours, and absolute downregulation hours to days. The earliest phase of desensitization blunts the receptor's ability to transmit a signal without actually removing the receptor from the cell membrane. The primary molecular driver is G-protein coupled receptor kinase 2, GRK2, historically known as beta-ARK1. In failing myocardium, chronic sympathetic tone drives a massive cytosolic upregulation of GRK2. When norepinephrine binds the beta-1 adrenergic receptors, the receptor undergoes a conformational change that exposes its intracellular carboxyl terminal tail and third intracellular loop. Cytosolic GRK2 identifies these active conformations and rapidly phosphorylates specific serine and threonine residues on these intracellular domains. The newly attached phosphate groups act as a high-affinity molecular beacon, drawing cytosolic beta-arrestin 1 and beta-arrestin 2 to the membrane. Beta-arrestin binds directly over the intracellular loops of the receptor. This creates a physical shield that blocks the receptor from interacting with its stimulatory G protein. The stimulatory G protein to adenyl cyclase to cyclic AMP to protein kinase A axis is instantly severed, dropping the intracellular calcium transients even though the receptor remains fully exposed to extracellular catecholamines. The second phase, endosomal sequestration, internalization, time frame minutes to hours. Once bound to the uncoupled receptor, beta-arrestin shifts from a physical blocker to a structural adapter protein, initiating the physical clearance of the receptor from the sarcolemma. Beta-arrestin undergoes a conformational shift that exposes binding sites for clathrin and clathrin adapter protein 2 complex. Vesicular invagination. The AP2 complex gathers the uncoupled beta-arrestin bound beta-1 adrenoreceptors and clusters them into clathrin-coated pits on the myocyte surface. The large guanosine triphosphatase enzyme dynamin wraps around the neck of the invaginated pit, constricts and pinches it off, pulling the beta-1 adrenoceptor inside the cell into an intracellular early endosome. The fate fork. Inside the endosome, the receptor faces a critical sorting decision, of which one is resensitization. If the catecholamine stimulus drops, intra-endosomal phosphatases strip the phosphate groups, beta-arrestin dissociates, and the receptor is recycled back to the sarcolemma. In chronic heart failure, the unrelenting catecholamine presence forbids recycling, forcing the endosome down the degradative pathway. And finally, the absolute downregulation, degradation, and gene suppression. Time frame hours to days. Because the hyperadrenergic state of heart failure does not abate, the internalized receptors are permanently purged from the myocyte's total protein pool. The early endosomes containing sequestrated beta-1 adrenoceptors are matured into late endosomes and trafficked to lysosomes. The vesicles fuse and intralysosomal proteolytic enzymes completely degrade the receptor proteins. Simultaneously, the prolonged activation of downstream transcription factors, specifically the inducible cyclic AMP early repressor, binds to the promoter region of the ADRB1 adrenoceptor beta 1 gene, actively halting the synthesis of new beta 1 adrenoceptor mRNA. Post-transcriptionally, specific cytosolic RNA binding proteins bind to the remaining ADRB1 mRNA transcripts, accelerating their enzymatic decay before they can reach the ribosomes. In a healthy left ventricle, the ratio of beta-1 to beta-2 receptors is roughly 80 to 20. Because beta-2 adrenoreceptors do not undergo the same aggressive GRK2 mediated internal destruction, chronic heart failure results in a selective loss of up to 50 to 60% of absolute beta-1 density. Consequently, the failing sarcolemma shifts to a severely blunted ratio of roughly 60 to 40. Post-receptor collapse, the GS to GI shift. The physical loss of beta-1 receptors is compounded by a profound pathological restructuring of the surviving downstream machinery. Failing myocytes explicitly upregulate the expression of inhibitory G proteins, that is GI. Persisting low-level protein kinase A activity in the failing heart phosphorylates the intracellular domains of the surviving beta-2 receptors. This specific phosphorylation alters the receptor's affinity, forcing it to uncouple from stimulatory GS and couple directly to GI. When circulating catecholamines bind these altered beta-2 receptors, they now send an active inhibitory signal to adenyl cyclase, throwing the molecular brakes on CAMP production. Without adequate CAMP to activate protein kinase A, the myocyte fails to phosphorylate phospholamban. Unphosphorylated phospholamban remains tightly bound to the SERCA2A pump, actively choking off reuptake of calcium into the sarcoplasmic reticulum. The sarcoplasmic reticulum becomes severely depleted of calcium. Systole fails because there is no calcium to release, and diastole fails because lingering cytosolic calcium prevents the myofibrils from relaxing. Understanding this precise molecular decay explains why beta blockers like carvedilol metoprolol, succinate, and bisoprolol, serve as the cornerstone of heart failure with reduced ejection fraction survival. By acting as competitive antagonists, beta blockers sit in the sarcolemmal binding pocket and shield the receptor from circulating catecholamines. This abruptly starves GRK2 of its target, halts beta-arrestin recruitment, stops clathrin-mediated endocytosis, and drops intracellular ISO levels. Given weeks of pharmacological shielding, the myocyte resumes ADRB1 transcription, resensitizing and upregulating functional beta-1 receptors back to the cell surface, thus explaining the role of beta blockers in chronic heart failure.